Nice, good. Now you're an orthodontist, right? You're not
Yeah,
or,
I'm orthodontist, but I love maxillofacial surgery also.
yeah. Where are you calling in from?
I'm from Kurdistan, as I send you invitation letters from Kurdistan region of Iraq, from the north,
Yeah.
from Suleimania.
Okay. Where are most of the participants? Where are they from? Are they scattered about?
The participants surgeons and orthodontists from my country and also some other country, neighbor country, because I have a lot of friends there.
And connections. It's very good.
Great. So please, can you share a slide to see we have no any technical issue? Yes, I can see your slide. Very nice slide. What's the name of this city?
So this is Toronto.
Toronto. Yes, amazing. Very, very beautiful.
I am right over here.
Yeah, very nice. Wish to come there one day and to see you in Toronto in person.
For sure. Do you
Great,
get
great.
to travel much to North America? I know some of the
I've
big.
never been to North America, but
Oh,
I
okay.
wish to go. Unfortunately, it's very difficult for us far away, and the visa process is not easy for us. From Iraq, the Iraqi passport holders, not easy to get a visa. But I wish to be there. Honestly, I applied for a visa scholar program for about 6 weeks for next year's. It's about cleft lip and cleft orthodontics.
Yeah.
So I hope to be nominated and coming there. Although it's a little bit difficult because there's just two seats for 100 country
Yeah, it's
developed.
been. Yeah, I mean, Trump has made it hard for even us Canadians to go into the U.S.
Yeah. But pray for me to come there and from
Yes.
Canada, from the States, coming to the Toronto to see you.
Yeah, lovely.
Thank you very much. So, fortunately, you have no any difficulty in sharing slide. So, in about 1 minute, we'll start. Before you start, I should introduce you to my audience, and later on, I will let you to start your lecture, your amazing lecture. So, by the way, how many slides you have and how much it take?
I'm figuring it'll be about an hour and 15 minutes, hour 10 minutes.
Yeah, it's interesting. So, your topic is interesting. Take your time. Maximum, you have 2 hours. So, it's up to you.
Yeah, and
Great.
I'll speak. I mean, this is similar to a talk I just gave last week. I was at the American Association of Orthodontists in Philadelphia.
Yeah, there was a meeting, AAO meeting in Philadelphia and
Yeah.
Pennsylvania.
And I gave a shortened version of this. So
Great.
it's
Great.
it's new, it's contemporary,
Yes.
new
I
slides.
see. I see your amazing chapters written in books about three-dimensional orthodontics, three-dimensional diagnosis and treatment planning orthodontics. I read your chapter. It's very, very interesting. I'm very happy. I'm very proud to see you tonight.
Well, even in my talk, like some of the references, I have a QR code, and I'll tell
Ah,
whoever your audience can scan the code,
mm,
and um, they'll have the articles, they'll have every little thing that's attached. The only thing, if you can, I know it's hard, and it's one of the difficulties in giving these talks, is to make sure that people participating don't copy my slides or images of my patients. Uh,
so, do you mind to record the meeting?
You can record the meeting, but just individual people taking copies of patient slides, it is copyrighted. So,
So,
uh, yeah, and I give permission to record.
don't worry, don't worry. I will not share with anyone. Just I'll keep it for my reviewing for next times.
Yeah,
If you don't mind, I'll record it. Don't worry, I don't share with anyone.
because the patients, and I'll mention it, patients do give consent for educational purposes, but not for dissemination. The problem is I've seen many years ago, I did some talks and then someone on Instagram is putting the pictures of my patients
Ah,
on their Instagram posts.
yeah, don't
Oh,
worry, I don't share the record with anyone. Just I'll keep it for me for reviewing because our topic is interesting, and I want to review it for next time for better understanding what you are saying tonight. So can we start?
Yep. Oh, yeah. I'm ready to go.
Okay.
Recording in progress.
So, good evenings and good afternoons, dear ladies and gentlemen, dear friend, colleague, resident, specialist, academician, clinician, and researchers from my country, from Kurdistan region of Iraq, from Iraq, and from neighbor country. Thank you very much again, and welcome again for joining us tonight. I'm Dr. Zana Hussein Aziz. I'm consultant orthodontist from Kurdistan region of Iraq, from Sulaimania, Maishti, the capital of culture of Kurdistan region of Iraq, at the border between Iraq and Iran. Tonight, I'm very happy and more than excited to invite one of the figures and speakers, international speakers, in maxillofacial surgery. Our guest speaker tonight is Professor Dr. Marco Caminetti from Canada, from Toronto exactly, talking about the orthognathic surgery, surgical orthodontic recommendation, virtual planning, clear aligner strategy. Welcome again, my dear friend, Dr. Marco. I'm very happy to see you tonight. Thank you very much again for accepting my invitation and for preparing such a nice topic for us. I'm very happy to moderate this webinar with you. So please, dear audience, record is not allowed. And if you have any questions, we are taking the question from you. So write them in chat box. I will direct your question to Dr. Community at the end of his lecture. But first of all, before starting, let me to introduce you Dr. Marco. Dr. Marco Community is originally from the Montreal and went to the McGill's University for undergraduate study in anatomy and then completed his dental study. He was in Canadian Army Force and serving in the United Nations. Then he came to Toronto for his residency in maxillofacial surgery. After residency, he was a surgical education fellow and division of the surgery at the University of Toronto. Then he continued as a Walters Lawrence Fellow in orthognathic surgery in division of the oromaxillofacial surgery at Toronto General Hospital. Regarding his current position now, he's associate professor and head of and program director of oromaxillofacial surgery at the University of Toronto. Also head of maxillofacial surgery at the Humber River Hospital and surgical director of the cleft lip palate program at the Holland Blue Review Kids and Rehabilitation Hospital. Also chief the missions of Face the Futures Foundation, and the community practice is focused on surgical orthodontics and virtual planning for management of the patient with a facial deformity, and his research focus is on the development and assessment of surgical skill. Thank you very much again, my dear Dr. Community. Now you can start your lecture and screen is yours.
Thank you, Dr. Hussein. Thank you for the introduction, and hello, everyone. From wherever you are, I'm trying to get a feel of where people are sitting in at home, and privileged to speak to all of you. And hopefully at the end we can also have questions if you want. I'm open to questions at the end. And right now I am seated, I don't know if you can see my little arrow, I am seated right here. That's my office. This is the city of Toronto. Here's the University of Toronto in the foreground. The CN Towers are famous location. And so this is where I'm from. Just before I begin the discussion, I have no conflicts to declare. Any of the companies that I mentioned, nobody's given me a penny. I don't ask for a penny from anybody, so I have no conflicts. Also, all the patients that I'll be showing have consented to show their images for educational purposes, but please not for redistribution. So a little bit about where I'm working. I work at this place here called Humber River Hospital. It is North America's only complete digital hospital, meaning that it is entirely paper-free. We have robots carrying things around. Everything is digitized. The operating rooms are modern. It's a new hospital. It's also one of Canada's largest hospitals with over 550 beds, but I think that pales in comparison to some of your hospitals. But for us, that's pretty big. I have a craniofacial clinic at Holland Bloorview Kids Rehabilitation Hospital. That's where I'll see the group of patients specifically with craniofacial anomalies. And I also work at Mount Sinai Hospital. This is our seat of the temporomandibular joint replacement program, which I co-direct with Dr. David Sutka. I also have a private studio, not really an office, where I see patients for consultation. I take photographs and scanning, and it's not really an oral surgery office, but it's all meant for pre-surgical preparation. I do all the 3D printing here, and the most important machine in my office is my little espresso machine there. I'm going to review more or less 4 topics over the time we'll spend together. And the first is ideal orthodontic goals for getting perfect setups. And it's wonderful speaking to an audience of probably mostly orthodontists, some surgeons, where I can scream and yell at orthodontists as to why they need to improve sometimes the setup or the setups or the diagnosis isn't done appropriately. So little goals on how to make things a little bit better. Another issue is the communication. Now with our digital age, and look at us here on Zoom across the world, there's no excuse that we can't communicate with each other regardless of geography. And it's important that the orthodontists and surgeons are linked together and come up with a common plan. I'll review with you what I do with in-house digital planning. I'm now 100% in-house digital planning, except for my custom TM joints, and I'll show you that. And I'll also show you what I think might be a problem with our over-dependency on digital planning. We can run into errors and just a few flags that you have to see. I think all surgical orthodontists, surgeons and orthodontists will say this prayer every morning before I do surgery, but our goal in surgical orthodontics is to get class 1 skeletal occlusion. All the teeth have to be on a stable alveolar base, have to occlude perfectly in an ideal functional pattern, and that means don't over-rotate things. I'll show you. We have to have good TM joint health and make sure that's aesthetically pleasing and without compromising airway or speech, and most often we want to improve that. So I think regardless of where we are in the world, I think all of us have this same concept, and this is one of the things that we have to go with. We can't isolate any of these on their own. We have to try to bring them all together. My base with orthognathic surgery is that it's occlusion based. I'm not a cosmetic surgeon. I can't do aesthetic cosmetic surgery in my government regulations here in Ontario. Other places in Canada can. So the first thing I tell patients is that I will be working on getting you the best occlusion possible. I will place that in the most aesthetically pleasing position, but no means am I a cosmetic surgeon. And that's really very important to share with our patients, because they can come back after surgery with a perfect result, what we think is a perfect skeletal result, but they complain that their nose is a little wider or their lip is not where they want it to be. I tell all patients that they can continue on to cosmetic procedure, but really we have to focus back on the occlusion. This is the occlusion that we like to see after our results. Yes, obviously aesthetics do play a role, but to me aesthetics is putting things in the proper position. So here's a young lady with a big cant, big asymmetry, mandibular retrognathia, microgenia, but I base the positioning of her lower facial structures on her occlusion. And yes, if you put things in the right place, there is an aesthetic difference. But I do emphasize that this is not cosmetic surgery. In Europe, there's a trend of making orthognathic surgery a cosmetic procedure. So all you're seeing is before and after of beautiful profiles, but they're not showing you the occlusion. And in my opinion, that's a failure. We have to strive in achieving the best occlusion. Similarly, we also have to improve patients for airway. I do see patients sometimes for airway issues. I'm very selective on that patient population, but I base it on the occlusion. And yes, they do look better, and yes, they breathe better. We hope so, right? That's for the purpose. So, but I still base everything on the occlusion. This is a typical patient week that I saw 2 weeks ago of the patients that I see in my practice. Right? So I saw an Aperts, I saw a patient with Turner syndrome, Down syndrome, hemifacial microsomia, hemifacial lipomatosis, hyperplasia, joint ankylosis. I see patients with genetic, congenital, prenatal problems. I see a lot of patients with fetal alcohol syndrome, Zika virus, some intrauterine molding. I see patients with acquired or environmental disorders, growth conditions, fibrosis, scleroderma, even trauma. Overall, about 3% of births have some form of congenital birth defect. So, I joke, I'm a surgeon, but I'm really an occlusionist. All those patients that I saw a couple of weeks ago, this is the occlusion that I'm dealing with. So I focus on the occlusion. I need good orthodontic support to get the teeth over a stable base, and then we get together and we plan what movements we need to make. A key presentation, and what you'll see during my talk, you'll have a QR code. So feel free with your mobile phones to go up to the QR code. You'll get a reader. You will get these presentations. So no need to take pictures of all my slides. I have it here for you in the presence of QR codes. If you, many of the orthodontists will know John Casco. He's at the University of Iowa. He's now retired. This is work we did, an interview back in 2012. I revised it in 2019, and it's probably due for another revision. But it is sort of 10 points of what I would need you as orthodontists to help prepare me to make better cases, how to prepare these cases. So 10 simple steps. Step number 1, prepare the patient. You, the orthodontist and surgeons, have to be able to prepare the patient, tell them what's going to come. We have to educate them. We have to communicate with them. The procedure has to be outlined. The orthodontists as well need to know that A, this is going to take a lot of time, and that it's a big surgery. This is not a small surgery. And in my practice, I only see patients from board-certified orthodontists or respirologists for sleep medicine. I do not see patients off the street. I'm not on Instagram. I don't want street-level referrals. I have referrals specific to me, which makes it a lot easier for me because then I know that these patients also have been prepared. Prior to the patient coming to see me, they get a brochure, they get a pamphlet, about a 10-page pamphlet telling them about jaw surgery, and right away, they know from the start, infection, nerve damage, reoperation, that's the complication. All my patients have to watch this video, and this video is registered in their chart. So they can't sit for the consult without my staff seeing that they've seen the video. They won't sit down in the room. So, and in the video, I tell the patients at the very end, I say, I'm going to quiz you as to what the complications are of jaw surgery. And it's great because if you get a teenage patient, 18, 19, 20s at university, they love quizzes. So the second I said, tell them at the end, I said, what are the complications? They will rhyme it off. And I've been in practice in 35 years. I've never had a medical legal complication complaint against me because of an infection, nerve damage, or reoperation. Because they're informed. They have to be fully informed of this. Step number 2, get good data. Again, there is no excuse in our digital world, even with your cell phone, to take proper pictures. You have to get a proper Ceph, a good panoramic image. I do 3D modeling sometimes. I put little marks on the skin if patients have a big cant or malocclusion, big asymmetries. I'll use radiopaque markers, good STL. I take STLs. I don't take alginate impressions. I do a Ceph. I make a Ceph tracing, and this is, in a sense, I'm preaching to the choir. It's the orthodontists. You do a good job at doing medical records, and continue to do so. One of the things that I'm seeing a little bit are orthodontists are using the scan of the teeth and using that as the photograph. I don't think that's a good idea. Still take pictures, pull out a camera. It's so important to show these patients. I find it also very important afterwards, because I've had some patients a year afterwards, they'll complain, they'll say, hey, you know, I'm still a little bit, how come I'm bigger on this side? And again, for cosmetic reasons. And then I'll show them the picture pre-surgery. And of course, I got great pictures, and I'll show them, you look the same pre-surgery. I said, the goal is to get your bite together. You know, I can send you to someone to fix that up. So good pictures are key. Also, this is, I find, is very important, that the orthodontist needs to help come tell me your diagnosis. Let me know what your treatment plan is so I know what you've told the patient. So my orthodontists have to fill out a digital referral form, and I've hidden the name of the orthodontist here, because all they wrote in the referral form was they checked off orthognathic surgery, They had some x-rays, and the only thing they wrote was missing lateral incisors. No, comes from a good referral. I know that the patient needs jaw surgery, but I don't have a sense of what the orthodontist shared with the patient. So what I really like is this. This is a referral. This is also all within the same week. This is like, and I left his name because he's a good orthodontist, just to give him a boost. So look, reason for referral, jaw surgery, x-rays, and then he starts. He gives me a problem list. He realizes the discrepancy. It's a class 3 skeletal malocclusion. There's asymmetry, there's crowding, there's open bite. Also, determine the need for surgery. Needs possible surgery, and I think he'll use it at maxillary advancement, on and on and on. So the orthodontist is with me, committing to a diagnosis and treatment plan. So that's what I mean by becoming understanding of the diagnosis, and let us know. So in the end, I say, I tell orthodontists, help me help you. So a blank referral doesn't help us, and it doesn't help the patient either. So I want to show you something it's mind-blowing. It's nothing like you've ever seen before. It's a reliable, it's a standard radiographic image. It's excellent for orthodontic treatment planning. I don't know if you're familiar with it, but hopefully it'll catch on. Okay? I'm joking, right? So this is a lateral cephalogram. CEPHALOGRAM. The reason I'm being facetious and speaking tongue-in-cheek is because we are seeing a lot of practitioners not take lateral cephs. We're seeing reformatted CBCTs with a pan and ceph, which in my opinion are useless. Take a lateral ceph. You orthodontists can take a lateral ceph. You can tell the gender, socioeconomic status. You can tell what car they drive. You're so talented in looking at cephs. So do not stop taking cephs. It's very important. I analyze the ceph because I need it for my vertical assessments, my angular assessments, horizontal. I agree, it's totally useless when it comes to facial, asymmetry, and cant. But laterally, it gives us a lot of information, 3 valuable points, right? I always take a cephalometric x-ray. If many of you use Dolphin, if you go into Dolphin, there's an analysis called the Steiner-Witz-Tweed. I placed that, probably 2008 for Dolphin, and I find this as a useful surgical assessment because in this assessment, I get a good idea. I use the Andrews analysis. Remember, the Andrews analysis you can only do with a big smile. It gives me a good AP position of the maxilla. If I want to get a good assessment of the vertical position, I have Steiner. I also use the COGS analysis. If I need to get an idea of rotation of the mandible, the Tweed is a good analysis. Incisor angulations are very important, and the Tweed will fish that out for you. Horizontal changes, I think the Witz analysis is excellent because it gives me a good idea that if your overjet is 5 and your Witz is 5, then you've done a good job of decompensating. If on the other hand, let's say the overjet is -4 and the Witz analysis is -10, then I know either we haven't done our homework and done a good job of decompensating, or I've learned, I never blame the orthodontist, you've had a hard time decompensating, or teeth that premolars were previously extracted, or something like that. So I'm very cognizant of my orthodontic challenges. My wife's an orthodontist, my sister's an orthodontist, my sister-in-law's an orthodontist, my best friends are orthodontists. I have about 75 orthodontists that refer to me. So I know the orthodontic challenges that you have. But the Witz is great, and it coaches both of us as to how we are doing with our horizontal changes. I like to look at the occlusal plane. Not everything has to be counterclockwise. And for the chin, I like to use the Holdaway analysis. Now, the Holdaway analysis only works when the patient's in a class 1 position. So if you have a patient prog, pre-surgical, Holdaway is useless because the angle of NB is completely off. So in my ceph, I will correct the mandible into the class 1, and then I get a good idea of basically the bump. How projected is Pogonian, and I get a good vertical assessment. So that's why I find ceph is very, very important. And to me, the positioning, how I position the maxilla is all based on the central incisor. Vertical, horizontal, AP. Then we also have to check the chin and cant and things like that. But the ceph is critical, critical. The first thing that we have to realize when we're doing our surgical planning is to determine the transverse discrepancy. And this is where models come in very handy. You must continue to do model analysis. A useful thing is with Invisalign, is if you're using Invisalign, is to look at their projection. They have a good study model analysis, so we can get an idea of how the changes is a case before surgery, and we can measure whether or not we have to do transfers. The easiest, obviously, is just with the models. So in a model analysis, number one, we need the transverse analysis, tooth size discrepancy, look at your arch length, look at the angle classification, but in skeletal malformations, angle classification isn't great, especially if they're missing some teeth. What I like very much is the Katz's classification, right? Katz's classification is the fourth tooth, 1, 2, 3, 4 tooth, regardless of what tooth it is. Premolar, molar, canine, won't be canine, but fourth tooth measured to where it belongs. So in this case, the Katz is a -5 on this side, so it's a class 3, -1 on this side. So Katz of -5, -1 is telling me it's a little class 3 skeletal and a little bit asymmetric. So I find Katz is very, very useful for surgical cases. So first assessment is the transverse discrepancy. So you can get your phones and screen this. This is a little calculator to help you decide if we have to do a surgically assisted rapid palatal expansion. This is a young man. I see a lot of patients at Holland Bloorview Kids Rehabilitation Hospital with amelogenesis imperfecta, the old AI. Right? This is a typical case. Very crowded teeth, very poor, it's not hygiene, but very poor dentition because of the amelogenesis imperfecta. There's mostly dent in there. They all typically are very constricted maxilla and a big open bite, almost all of them. So the first thing I have to do is widen the maxilla. This is not his case, but just to showing the type of appliance I use. So how wide do I have to make the maxilla? I like to look at the maxillary transverse discrepancy score. This is a guide. I'm now in the process of looking at almost 200 cases to try to make it as a reliable and a valid assessment tool. But regardless, this is just meant as a guide. It's also a good communicator between surgeon and orthodontist. So you look at the inter-arch distance, so the distance between where this would be in a class 1 position, central pit of the upper sixes, the distal buccal cusp of the lower sixes. So I measure that. And I give it a scale, I give it a rating. I look at the buccal segments. Is there a tooth arch discrepancy? Do we have to extract or non-extract? I look at the mandibular curve of Wilson, whether it's flat, so we've achieved our width of the mandible, or it's very deep, and we still have to upright those mandibular teeth, and we increase the transverse discrepancy. I also look at the negative space, if it's mild, moderate, or severe. So the score, then I give this each one a little number, and we try to come up with a score. So less than 6, we feel that we can probably manage it orthodontically. Between 6 and 7 with a Lefort, greater than 11 managed with a Sarpi. Okay. This is what it looks like. So this was started by Dr. Daniel Richmond, who at the time was a resident in orthodontics at the University of Toronto. He's now in private practice. This is the calculator here. And what the calculator does is it will help me plug in some numbers. So I'm going to see if this works. Dr. Hussein, you're able to see this?
Yeah, I see that it's just tables.
Surgical expansion calculator?
Yeah.
Perfect. So here, for example, let's say the transverse discrepancy is only 4 millimeters, but the teeth are buccally inclined. You don't want to extract, and the curve of Wilson...
Excuse me, you are showing us a picture? I cannot see any pictures of the patients.
Let's see.
I just see the tables for the calculators with the barcodes.
Oh, okay, here. Has it changed?
Yes, now it's okay. I see the table just,
Okay, good.
yeah.
Yeah, so this is the calculator. So 0 to 4, buckle inclination, mild extraction, and a deep curve of Wilson. The calculator says, you know what, you should be thinking of doing this with a surgically assisted palatal expansion. And it helps, let's say you have a very large discrepancy, 8 millimeters, but the teeth are lingually inclined in the maxilla. You have to extract teeth, and the curve of Wilson or your mandibular reference is flat. You may not need a surgically assisted rapid palatal. You could possibly do this with a Lefort. And if the transverse measurement is very small, you're looking at orthodontically, you can try to expand this as you will. So this helps a little bit in your assessment there. Okay, I'm going to go back to my slides. Okay, we're back again. Right, so this expansion calculator works really well. So Dr. Richmond has many other ones for crowding and extractions, the CATS classifications, all there. So this is very handy. But for surgeons, this is helpful because surgeons, we're pretty dumb. So in order for us to go, oh, it's a huge constriction, we have to do a SARPI, no. Look at it carefully. Look at the teeth, look at the arch size. So it just makes you think a little bit more. So I use, for my surgically assisted rapid palatal expansions, I use this device that I designed. It's a TAD retained acrylic palatal expander. And it's placed at the time of the SARPI. So the reason I switched to this is because the Hyrax appliances that are bonded and then we do the SARPI, you don't know if your two halves of the maxilla are moving. Sometimes they get stuck. So at the time of surgery, and remember, surgically assisted rapid palatal expansion takes 15-20 minutes. It doesn't take long at all. Under general anesthetic, though, and cut across the maxilla, cut across the midline. I make sure that the two halves of the maxilla are mobile. I sew everything up, and then I place this appliance. I screw it in with rigid fixation screws. I don't use TADs because they need to be a little bit longer. And this is the device 3 weeks, I think 21 days after expansion, and then this is at its removal 5 months later. And you can see the tissue underneath is clean, it's healthy, it's a little irritated from the screws, but this heals up like nothing ever happened. Right, so this works really well. So I kind of suggest for surgically assisted rapid palatals to place the device after you've confirmed the movements of the hemimaxilla. So back to our case with the amelogenesis imperfecta. Pre-surgical, I do the expansion here. Look at this nice expansion that we got. He needs a second surgery to close the open bite. So maxilla, mandible, chin surgery. We have everything right. I'm showing this case because it's a little bit of a heartbreak when you put so much work into it and our general dental colleagues go and finish it off like that. And that's pretty awful. I'm just also showing this that I didn't do the crowns and bridge. That's probably what they'd look like if I did it, but obviously a little bit disappointing, but we achieve our inclusion. Okay? One of the things that we all have to agree with is that the treatment plan, although is orthodontically driven, we have to base it on our surgical limitations. So orthognathic surgery is orthodontically driven and directed. But you need to know the problems. Every orthodontist loves to quote profit. This is a 2007 publication, but this is actually stuff that was done from the late 80s, early 90s. I don't agree with this at all. This is my degree of stability, what's working in my hands. Your surgeons will be able to tell you, they will probably all agree on this. A Lefort downgraft is unstable. However, if I do a Lefort downgraft with more rigid plates and bone grafting, it is more stable. So we know that impactions are very stable. But if I do a big impaction with segmentation and advancement, that becomes less stable. So there's no set movement. We try to do everything to make it stable. But we all together need to know that I can't do a big expansion and advancement. That's completely unstable. You're better off doing a SARPI surgically assisted rapid palatal, and then doing the Lafort advancement a year later, that's much more stable. So that partly you need to work with your surgeon to figure out which is the best way to go. All the orthodontists.
I mean, can you make your slide full of screen?
Oh, okay.
Go to play to be full of screen.
Let me just hold it and start it up again. Is that better?
Yes, it's full of screen, but I see that first light.
Yeah. I'll. There we're catching up here. Okay, so transverse. So our next step is understanding the instabilities, and then finally decompensation. And this is everything orthodontists know. You have this set. You've got your movement. So decompensation is very straightforward. Level and align. Put teeth over basal bone. You want to flatten any curve of SPE, except if it's a very deep bite. Class 2 mandibular retrognathate, you may not be able to flatten the curve of SPE. I know that's a challenge. So we can do surgery early and then flatten the curve of SPE. Now that I mentioned that is, I do not do surgery first. I don't understand why people would want to do surgery first. I think luckily the world is turning away from that fad. I will do surgery early, but I find the results are incredibly different. I have a whole other lecture series on picking on surgery first. Anyways, we'll go on that. So surgery early, I believe in, but not surgery first. Make the discrepancy worse. Right, some cases come with a compensated class 2 proclined incisors, and you want to do mandibular advancement. Take out the premolars, pull up those central incisors, give some more overjet, make that discrepancy worse so we effectuate a better change. We can maximize the surgical change. Also, very important is allied staff who are helping. And I know in orthodontic offices, if a lot of hygiene is involved, and hygienists know how to compensate occlusions. That's what they're used to. Your allied staff needs to be aware it's a surgical case because that surgical patient needs a little bit more tender, loving care. And take study models. For goodness sake, take study models. Wisdom teeth, this is sometimes a debate. Oh, we can take wisdom teeth out at the time of surgery. I do that all the time, and some of my best friends are down in the U.S. who are big orthognathic surgeon, Brian Farrell, everybody knows him. He takes them out at the same time. He and I have fights all the time, and I always say take them out. The literature is not equivocal. It is better to remove them before. The problem is yes, you have to, your patients end up enduring 2 surgical procedures. But taking wisdom teeth out at least 6 months before will cause you to be able to put on your fixation, less bad splits, shorter operating time, better bone stock, and I believe lower infection rate. That's something that I'm looking at in my studies. So it's so easy. Get the patient involved, get the orthodontic started, get the wisdom teeth out. And then by the time you've done your level and alignment and decompensation, the bone is healed and they're ready for surgery. Just take the wisdom teeth out. Good TM joint health. I always quiz orthodontists. So let's say you have a 22-year-old healthy patient getting set up for pre-surgical orthodontics, wisdom teeth are out, but now she's complaining of pain, 6 on 10, both joints while eating. So what do you do? Who goes and drops everything, takes off all the bands, and then says, "Run for the hills"? I'm not. You can't have jaw surgery. Who will tell her, "Oh, this is perfectly normal. Come back in 6 weeks, 8 weeks." Or B, correct answer is B, manage the symptoms. You have to learn how to manage these symptoms in your patients, and this is to the orthodontic population. Many of my orthodontists might just give me an email or text me and they say, "Hey, this patient's having some pain. What's your recipe?" I have a recipe. I don't deal with TM joint pain. I'll do joint replacement, but we all have our own little formula of heat, massage, anti-inflammatories, muscle relaxants, maybe a splint. Do something just to help them out palliatively. Almost always they will do better. It never gets to the point where you have to take the braces off, right? If it's getting worse, if there's evidence of real serious arthritic condition, let me take care of it. Let the surgeon take care of it. Still don't abandon treatment. We might need to delay things. Then we'll get MRIs. One of the things that I do quite often is disc plication. So if patients have, here in this image here, a severely displaced disc, what I'll do, I have a case report. It's being published in the International Journal soon. I take this disc and I will pin it back right before the jaw, at the time of jaw surgery. They're put to sleep, and the first thing I do is make a little incision, tiny little incision here. It's on the inside of the ear. I grab the disc, pull it back, and I pin it into place. And this is what the pin looks like. Then I'll proceed, do Lafort sagittal split. This is the same patient, right? And what I found is that patients who have a nauseous, painful, disruptive, arthritic, internal derangement, this really helps out quite a bit. It doesn't alter their occlusion. So anything with a painful loading click, this plication works very well. Because I find that you can see the difference sometimes in these joints. Like this is a sort of a malformed joint because the disc has been displaced for so long. The joints don't grow that well if the disc is not in the right position. And just to give you an idea, so this is right before the time of jaw surgery. Here's the disc. Here's my suture holding the disc in place. And now here with the movement, you can see as the condyle moves back and forth, right there, the disc stays in place. So that nauseous popping click is gone. So very useful. Let us help you with TM joint issues, but if the patient has some TM joint symptoms, don't abandon treatment. Another very important thing is ideal orthodontic support, mechanical support. The last thing I want to see when I'm tightening on my wires is this falling on the table. That never happened. I think this has almost become a joke in the orthodontic world, but banding the molars would be very handy. I know most orthodontists are no longer banding molars. If you can, at least band the sixes. The main reason we need some strong banding is here while the patient is wired. When I apply screws, the torque on this screw causes the bony segments to move, and that causes a little bit of a posterior open bite. So the stronger we have an attachment, the stronger we can hold. It's really important during maxillomandibular fixation. I tell the orthodontist also to make sure you put the heaviest wire that the slot can fit. Right? This is insufficient, just a little hook here. This is a patient who presents prior to surgery with no hooks and ceramic brackets. Ceramic brackets are beautiful, but they chip off and they land into the wound. So I don't like to see this. Metal brackets are good. And eventually also make sure you put hooks. This is a little bit overdone, but the best hooks are the crimped closed hooks, ones that are closed. Slide them in and then crimp them in place like this. Crimped open hooks like this, or the trillium hooks, that's very popular now. Soldered hooks used to be the way to go, but I find the solder, they're a little bit too short and they tend to fall off. Power pins that go inside the slot are an alternative, but they do tend to pull brackets off. The hooks on brackets eventually we'll have to use. They're not the best. Kobayashi hooks, like I showed in the previous picture, are eventually useful, and of course nothing. So in this order, please try to get the top three. I don't know if anyone's using light force. Light force, these hooks are very problematic, right? These are custom brackets. These are awful. They shatter. We can't put wires around them. The pieces fall in the wound. You never find them because they're radio lucent. I actually met with Light Force last Thursday at the AAO, and I met with the CEO to see if they can make sure that they make these radio opaque. And they said they are making changes to the brackets. And if not, just use a trillium hook. I like using trillium hooks. For about 10 years, trillium hooks only came in the two sizes, small and medium. I got them to make a 3 millimeter one. So I really like trillium hooks. Orthodontists like using them. I have a trillium hook case. I bring it to the OR just in case they pop off or if I want to put one on. So the tall ones are very good. The short ones are really hard for, they're useful for us, but not for patients. They can't put elastics on them. Let me show you the perfect orthodontic mechanic setup prior to jaw surgery. When I see cases like this, it brings a tear to my eye. Makes me so happy. Look at all these beautiful 3 millimeter hooks. I got a big stainless steel wire in there. Every one is tied because I may segment. And if you have a tie of all the teeth, it's hard to segment the cases or it just unravels the wire. And then 3 millimeter hook. Now, this is a lot. This is a lot. I like to see them at least between the centrals and around the canines and just before the molars. And then make sure you have hooks on the molars. This is beautiful though, right? So these are the trillium hooks that work really nicely. Dr. James Noble. And this is all we use it for. So this is my intermediate splint. So I'm doing mandible first surgery here. This is at the time of surgery. I put in the intermediate splint. I make my splint so that I can see the teeth fit in there perfectly. There's no obstruction. I wire it down with 6 wires. This is not going to move. And I put in my 3 screws here, 3 screws here, solid as a rock. And I know it's not going to move. And this is, we're using this merely for about 10-15 minutes. I can't be a surgeon without showing some surgery. This is how I apply my rigid fixation. I use a special type of gun. It's a battery-operated gun. Here's a small advancement of the mandible. Here's my splint in place. Here's my wires. I go through the buccal cortex. My first screw is a lag screw. I do, if there's any surgeons watching, I do a cheating lag screw. So I use the first drill and widen it with the first drill. I use power, drill setting, and this screw is then set into the bone, fits in the slot of the lag, and gets tightened like that. That's a lot of torque. You can see at the end, I just make sure that it's seated well, and that can twist these bones, and with a nice solid fixation, that doesn't move. So that's all we need the hooks for. We need the hooks to put this splint in and to make sure that there's no bony movement. Or there's no movement of the occlusion as we set the bone together. And then I need the orthodontist also to assist in post-operative monitoring. That's very important. I want the orthodontist to see the patient 6 weeks afterwards, review the elastic pattern, retie any segments. If there's a big expansion, I want a TPA placed. So I'll communicate with the orthodontist about that. I don't want the orthodontist to see the patient in the first 6 weeks, because if I'm overcorrecting at class 3 and they're a bit class 2, the orthodontist panics and removes the elastics, and all that does is get me mad. Don't touch my patients for at least 6 weeks. I typically use 6-ounce quarter-inch elastics in the direction that I corrected. It's almost maxillomandibular fixation, 24 hours, tight elastics for 14 days. Patients actually like this. If you make it loose, they move around, it hurts. This keeps them stable. And I reduce it over 2 weeks, overnight. Then finally at 6 weeks, they're off to the orthodontist, and you can use whatever elastic you want. Every time I see the patient post-op, so the first 3 post-op visits, I put a date as to when I saw them. I use a marker, a skin marker, as to where I want the elastics to go. I indicate to them the type of elastic and how long it needs to go. I watch them take a selfie. They have to take a selfie of their elastics, and they have to follow this carefully. Very important. Because a patient puts this in the wrong direction, it screws everything up. Right, so that's a pre-surgical preparation. This is the city. This is the view from my condo in Toronto on a foggy morning. The city there. I want to I know this wasn't part of what I told you I'm going to talk about. I have a bee in my bonnet, which means that's an expression saying it's something I have to, sort of a public service announcement, my opinion of MARPs. And MARPy is the new drug for orthodontists. Everything needs to be treated with MARPy, the savior of the world. You know, it's problematic. I find here in North America, a lot of patients, I think around the world, go to Reddit and they get their opinions about orthodontics and surgery, and oh, I have sleep apnea, oh, you need to get a MARPy, only go to surgeons and orthodontists that use MARPy, only go to surgeons that... Reddit is a drug in North America that's very problematic for patients. And again, that's why I'm so privileged to be able to have a 100% referral practice only. The issues with MARPy or MSE, the reporting is hyperbolic. Now, I'm going to go through a couple of studies with you. The evidence is everybody's writing on MARPy, but the quality is very poor. Okay? A lot of false hopes. It's driven by TikTok and Reddit. So you really have to dissect the literature. I've done MARPys. I still kind of do some MARPys for orthodontist modifications, but I find nothing but appliance failure, non-compliance from the patients. They don't want to wear this for 6 months and twist it one turn every 2 days. They don't want to do it. You'll get expansion, 100%. You'll get 2-3 millimeters. If that's all you need, then great. It's great. But I find it's a lunch bag letdown. I'll explain. That's a Canadian expression. I'll explain that later. But this is the type of patient that comes through social media. This patient wants a MARPy. He says he has hypoplastic maxilla and sleep apnea. These are his words. He has all the language. He knows exactly what he wants. 4 orthodontists he's visited independently. One of them finally sent him to me just so I could speak to him. All the orthodontists recommended extraction. It's so wide. He says no expansion. He wants a MARPy. He wants his super wide jaw to be even wider. He had, the referral is not directly for orthosurgery. He never went to a sleep clinic, but he says he has sleep apnea. So I asked these patients if they go to Starbucks or if they go to coffee shops. And they kind of look at me funny. They're like, most everybody goes to a coffee shop or a tea shop. I said, what you're telling me to do is you have a medium-sized lower jaw and you have a medium-sized upper jaw. They fit perfectly together. But what you're telling me to do is that you want me to make your upper jaw a large size. You're going from a medium lower jaw to a large upper jaw, and it's just not going to fit. So the coffee cup analogy is fantastic for patients. That upper teeth have to snap over the lower teeth, just like a coffee lid or a teacup lid. So the small, medium, large, in the language of Starbucks, you got to ask them if they know Starbucks. Here's another crazy patient. I have severe sleep apnea. He needs a maxillary expansion. He wants to do this with a MARPy, not a SARPy, because it's a severe constriction. He saw 3 orthodontists and 2 other oral surgeons, and one of the surgeons asked me just to review with him the need for surgery. And this is what the patient came to my office with. This is from the orthodontic office. While he was talking to me, I realized that he was fitting into an overjet, a normal overjet. I grabbed him by the beard, brought him to the cephalometric x-ray, kept him in place. As we were about to take a picture, he throws his chin forward, but he kept the bite, and he has a perfect occlusion, perfect class 1. So I adjusted the x-ray, pre and post-op. So this is what he came with from the orthodontist, and this is the x-ray I took. So he's obsessed. He has sleep apnea, never had a study. He's snoring, not reported. He's psychosocial issues. He doesn't have a girlfriend. His life is in ruins. He believes the MARPy, because he saw this on Reddit, is going to change his life. He's imploring that I do surgery on him. The problem with MARPI and these maxillary skeletal expanders, all sorts of different names, don't kid yourself. A dome is nothing but a SARPI. The surgeons and orthodontists are writing publications. Look how I'm coming up with new, like it's a little bit silly. It's a little bit silly. Okay. Here's an original article in your orthodontic journal. This one's quoted very often. This is a big one. Angle orthodontist, the great angle orthodontist, right? Okay. I have to sit up for this one. So let's dissect the study. This is for all the orthodontists who really love their MARPIs. Study started with 69 patients. 20 right away were lost to follow. Okay, that's fine. I do research too. I know that happens. 9 of them had their appliance. So 9 of the 49 had the appliance not work. And then for some reason, they were excluded from the study. Final reporting on the 20 patients. So there's another 20 that are missing. So really 40 were lost to follow-up. This report says that the mean you have to go into the results to look at this, right? You know that. You go to papers, you go straight to the results. The mean expansion was 4.53. But if you add the 9 failures, you add that averages to 1.8 millimeters. But their conclusions, and this is what everybody quotes, suture expansion occurred in 60 of 69 patients. This is outright frank a lie. Right? And it's not being retracted. But it's referenced everywhere. Here's another study, just looking at RME, the efficacy of RME with OSA, obstructive sleep apnea. Okay, a meta-analysis. So it's just reporting RME only on AHI. The differences were measured RME right before the RME and then 3 months afterwards, after the device was insertion. Not after removal and not a year afterwards. So the mean reduction of AHI, remember, AHI is a whole number. So this is 3, not 3.24. Mean starting AHI was 5.4, it was 5. So if any of us who are knowledgeable about OSA, AHI of 5 is not OSA. It's mild to no sleep apnea. But the results of this meta-analysis, very often quoted, is that overall reduction in AHI after an RME. That's a little bit much. In this same study, they show this picture. They say, look at the airway volume we got with CBCT. And I'm like, well, hold on, you're talking about RME expansion. And then I took a closer look, and all they did was either the patient was positioned forwards, but I think they may have had surgery because I see little brackets here. So this is a different incisor position. So of course this airway is bigger because you're anyways, don't get me started. Don't get me started. This is not, what the heck? This is not right. So last week, Dr. Moon, who's all the orthodontists are Google Gaga over Dr. Moon, what's new and improved with a MARPI? The latest update on appliances. So even he started, this is in his abstract, okay? And in his abstract, he's saying already, the success of MSE has not been predictable. A lot of efforts try to improve the design. The impact on airway, it's being questioned. The true impact is not defined. This is in his abstract, preparing you for the lecture. Basically sharing us, the stability is not great. And I find, so MARPI, MSE, all that is a bit of a lunch bag letdown. And then, God bless you orthodontists for taking these out after this is one of my patients that early on from a few years ago. The tissue overgrows, they didn't get the expansion. So lunch bag letdown is a Canadian expression. When your mom used to make you lunch when you were in elementary school, and then you opened up your lunch bag and you looked and you were disappointed. So that's a little bit of what the MARPI is. So sorry, I went off a little bit on a tangent. Okay, digital planning and orthognathic surgery. Dr. Hussein was telling me that he was reading this chapter, so I have the chapter here for you. I wrote this in the 3D orthodontic book by Dr. Jean-Marc Retrouvé, who's in Kentucky. So scan this. This is a joke. Buffalo meat is expensive because it's very hard to get buffalo meat. So this goes over step by step, and I'm going to go over this quickly because it's quite detailed, and the chapter will outline it. But the one thing I want everyone to know is, regardless of what we call it, virtual planning, digital planning, virtual surgical planning, medical modeling, it is all nothing but a fancy articulator. Even in my office here, I have my 3D systems. Everything is all set up. It's nothing but a fancy articulator. Instead of stone and plaster and acrylic, we're using STL, DICOM, and resins. Right? There's no difference. Eventually, your clinical exam is the key and the veto. You can't let these computers tell you what to do, or they'll take over the world. I'm going to go through over these 14 steps quickly, just to show you how I do it in my sequencing, and I think we'll all be in agreement, and it's important as to where I specify digital versus analog, what's important. So segmental maxilla is the first thing I want to know. So just like the transverse discrepancy. Where do I want to segment? It's not always between both lateral and canine. Sometimes it's just the one side. Sometimes it's between the 3s and 4s. So I want to know if I need to segment the maxilla. That's very important. Because also it is important for my staff to know when they book the surgery how much time I need. Head position is very important. Everybody's got their own little head position lines. Ortho, you guys are going crazy. But this is the same person. Okay? A famous model. Here she is with her chin up. Here she is with her chin down. Here she is with full face, normal facial head position. The difference being, if I do a maxillary advancement in this patient, if I take my records in this position, I'll be vertically augmenting the maxilla. If I do a maxillary advancement in this patient, I'll be impacting the maxilla. So it's very important. It is important. It's not just, oh, the digital plan will correct for it. You have to take your records properly. I focus all my virtual planning on the position of the eyes in non-syndromic patients, right? 90% of my orthognathic is non-syndromic. So most I got to look at the eyes, and that's how I set everything up. I'll put the patient in the cephalometric X-ray. Right now, I send the patients all to an oral radiologist, or the oral radiologist will do this. On big cases, big cats, we'll put little markers. Put a little tragus here. So we take the pan and ceph, mark horizontal, then the patient goes to the CBCT with the centric relation record and these markers, and then we'll get these little points to help align the head in the proper position. I don't do this for all cases. It's only for cases that have big asymmetries in big cats. Then I got to decide where my midline is. And my midline is based on the eyes. I focus on the eye, then I drop a perpendicular to the philtrum. That's my midline. That's also where I determine my cant is. So here, for example, is a case where this is a big prog, class 3, maxillary advancement, mandibular setback. I go here and I do the eyes perpendicular to her, and her midline clinically is on. You can see there's a little tilt. Pegonion's a little bit shifted to the left, but her midline is bang on. Okay? If you depend entirely on the digital plan and go to Nasion and ANS, it'll indicate that the maxillary midline is off. This is why I've abandoned using virtual surgical planning companies, and I do it myself. Because the engineer will tell the surgeon, oh, let's move the maxilla over to the right 2 millimeters. And as all of you know, listening to me now, the worst outcome you can do is an asymmetry outline. Patients can tolerate a little relapse here and here, but if your midline is off, it looks awful, and that's a disaster. So use the eyes. It's a soft tissue measurement. I use that contact point as my movement for everything. XYZ plane. Vertical, horizontal, rotational. I use the central incisor as my point. Centric relation is very important, especially if I have to do big impactions. I got to determine the hinge axis. That's a whole other lecture. But as I said, central incisor position is the key. That helps me determine, in this case, the big vertical. How high am I going to put that up depending on the smile? Horizontal AP, how far to bring it forward. Again, I look at all my cephalometric numbers. And then I look at Tweed and aesthetics about the angular position. So incisor angulation, orthodontists, you know this all very well. It's important. It helps with the creation, if you take your teeth out, or elimination of space. It helps with mechanic selection and your prescription in the anterior teeth. It also influences smile aesthetics and has an effect on the occlusal plane when we're altering incisor angulation surgically. Occlusal plane correction is my next step. It's not always counterclockwise. Sometimes it's clockwise, and I'll show you why. A case like this, very deep bite, class 2, div 2, now all lined up, you can't steepen the occlusal plane. Be very unaesthetic. So we got to steepen it a little bit. There's nothing wrong with steepening occlusal plane. If you do so, you will upright your proclined incisors, you get a better fullness at SN, reduces pagonion, improves cuspid rise, function. Right now this is a group function occlusion. It'll increase cuspid rise or anterior disclusion. What we say to my kids, I used to say that, turn that frown upside down. So if you have an inverted U-shaped smile like this, it will improve it. It'll create a more U-shaped smile. This is this patient here, just by changing the occlusal plane a little bit. And this is a clockwise rotation. There's nothing wrong with the clockwise. The problem with clockwise rotation is if you overdo it, you get this look here. You may not be aware, Cindy Lou Who is a cartoon character by Dr. Seuss. And they all look like this. They all have a upturned nose and big prominence of SN. So I call it the Cindy Lou Who look if you overdo the SN prominence. Then in my steps, I find the best occlusion. I have a heat map, occlusal map digitally. I now determine this all digitally myself. After many hundreds of cases, I have no problem setting the occlusion digitally. I don't need models. A little note about Iowa spaces. Iowa spaces are very common, done distal to the laterals. They allow us to put the canines in a class 1 setup, period, without having to worry about the front teeth. It's not meant for spaces, for segments. It's not meant for that. It's all about mitigating relapse. But the problem is it distorts 3D planning. Because remember, I just told you I use my central incisor. So if you do an Iowa space and dump it out, my central incisor position is a little bit, it's untrue. So I don't know where to put that. So I don't recommend so much Iowa spaces as much. And on the topic of segmenting, I always tend to segment between lateral and canines. Very rarely between the canines and first molar. That little premolar tooth likes to get cut off, especially the palatal root. I use it a lot for open bites and tooth discrepancy. But I tell orthodontists just to keep the teeth straight up and down. Do not create a space between the roots, because that screws up the position of our crown when we're doing VSP. Because then suddenly we have to do enameloplasties because we've moved the crowns, we're trying to set it, it's interfering, you have to trim off the enamel, so then you can do your segment. 6 months later, you're uprighting the teeth, and then you lose your contact. You'll get an open contact. So I just say, keep them straight and parallel. I'll determine where to segment. And anyways, we don't cut between the roots. We cut between the roots all the way up to this point. Then we scratch the buccal surface, and then we split it open. We don't do a full cut, so we don't manage not to cut our roots. So it's important. Then the final steps in my plan, I look at the yaw, any interferences in the bone, I do my genioplasty, I decide whether I do maxillar mandible first, and I print my splints. Now, maxillar mandible first, 85% of the cases are mandible first. I do maxilla first when there's a big asymmetry, where I'm in a redo surgery, I tend to do maxilla first because I want to make sure that I have my central incisor in the right position. And big impactions. Okay? So moving along, how are we doing? Still got you. Clear aligner orthognathic splints. Controversial, but hopefully not controversial anymore. So this is an article. I have several articles, some in the surgery journals. This one is for orthodontists. Geez, it's already 5 years old. So orthognathic surgery with clear aligners. So you can sit back, relax, scan that, and they'll have some of the pointers. A lot of that's in there. These are the typical splints that I'll create. So I designed a splint called the clear aligner orthognathic splint, which is short for chaos, just to stumble things up. So in clear aligner therapy, ClinCheck has a problem with surgical cases. So here, for example, is a class 3 maxillary constriction, mandibular asymmetry, right? The mandibles all face symmetric. Previously treated with full fixed, but camouflaged. Okay. They tried the best, got the teeth nice and straight, no fault. The patient didn't want surgery. 3 years later, the patient says, you know what, I want to have surgery now. So now you're dealing with a compensated occlusion, but once it with clear aligner treatment. So patient goes into Invisalign, and this is what Invisalign does. Invisalign, let's bring it back. Invisalign will do everything possible to compensate the occlusion. The algorithm for Invisalign is compensatory. It's not decompensatory. So you always have to tell them. So clear aligner technology is focused on compensatory treatment. So you have to communicate with the technicians, no, this is a surgical case. All of you, when you're doing your aligner cases, you have this form in front of you. I know that. Remember, I'm married to an orthodontist. So you got the arch to treat, teeth to treat. You have this green part here. What I've done is I've added the surgical component, reasons for you to change some of the things. So let's just go through it. I know this is a busy slide. I have an isolated picture for this to use. Let's say you want to change the AP relationship in Invisalign, non-surgical. You want to improve that, obviously. If it's a surgical case, you want to maintain it or make it worse. Remember? Make this discrepancy worse so we effectuate a better change. Okay, let's shift gears. Midline. In a non-surgical case, your regular day-to-day Invisalign case, you're going to correct the midline with IPR. It will do that for you. It's going to set the trays knowing you're doing IPR. It even tells you how much to IPR. But if it's a surgical case, you want to maintain that. You don't want to correct it. We're trying to move the bone. Okay? Unless it's a single jaw case. But this is a really handy little thing when you're doing your cases. This is the QR code for this sheet here. Very useful planning tool for orthognathic clear aligner cases. It's also interesting. It also helps you with non-clear aligner cases just to think surgically how to set things up. Okay? For a second. So with clear aligners, it's definitely a challenge. The first thing I want people to understand is I'm not an advocate for clear aligner braces. I'm not an advocate for clear aligner surgery. The issue is that we're going to have to do it. 20% of my cases now present with clear aligners. And I'm not going to throw them out of my office. So we have to find a way to work with the systems and companies. So for sure it's a challenge. The prescription is difficult to control. Finishing is not perfect. Non-surgical, surgical, we all know clear aligner finishing is not as good as full fixed. 100%. Some cases with clear aligners are hard to treat. So extraction cases, deep bite cases are really hard to treat. Some cases are easier to treat. So multi-segment maxilla is a breeze. Surgery first. Remember, I don't do surgery first. I'll do surgery early. These cases are easier to treat. Patients with amelogenesis imperfecta, they're fantastic with clear aligners. The biggest issue was, from a surgical perspective, is how are we going to fixate these cases during surgery, right? I showed you the ideal setup. So would you use arch bars? Our patients with clear aligners will not tolerate an arch bar, and this is brutal. It kills the gingiva. MMF screws. These are big. These are bulky. We use them for fractures, temporarily during surgery only. We can put TADs in, so I do that. I will put TADs. I won't use an IMF screw. You can put in screw-retained arch bars like this. This is called an Omnimax, where it's digitally planned. The root scope that's planned between the root. This is just as bad as an arch wire. The little buttons. Sorry. Orthodontic appliances. Some orthodontists will put all the appliances back on a patient. Oh boy, our patients won't tolerate that either. That's the reason why they have clear aligners, is that they don't want that. Putting buttons on. Here, these tend to fall off. I started off putting on these little brackets. I'd have the orthodontist apply the brackets as apical as possible so they wouldn't shear off. And this worked pretty well, but again, there's metal brackets, or you can put the buttons. So that's one of the ways to get around it. Or what I do now is a digitally created full covered splint called the clear liner chaos splint, or sometimes called a tray splint. So it fits all the teeth. So it's good patients without orthodontic brackets. Sometimes I'll use these patients for maxillomandibular advancement who have no braces and a good occlusion. You have to remove all the attachments. It engages the undercut. So this is intraop. This is at the time of surgery. I use also the TADs just to hold belts and suspenders, hold everything together. This is immediately after it's removed. Right? This is what we want to see all the time. So these are hard resin. It's not the Invisalign resin. It positions we cut the maxilla, it snaps into the splint. The mandible snaps into the splint, and it's hard to remove. So it gives us good retention. We'll also supplement it with some wires. It's fantastic with segmental cases, because I'm able to take the 3 segments of the maxilla, snap it into the splint on each side. It's a gem to work with, much better than with braces and little wires. Here's a quick case, class 3, mandible. I'm using an intermediate splint with mandible first, putting the mandible back 4 millimeters, forward advancement of 4 millimeters with a little occlusal plane changes. See all the attachments are off on the patient, and this is what the splints look like. 2 weeks post-op, here's the bite. I have good contact in the front, still a little open here, but good contact in the back. This is only 2 weeks post-op. I like good with clear aligners because it's so clean, it's easy to suture, the wounds heal a little bit better, the patients tend to be a little less swollen. So it's surgically, I don't mind it, and your surgeon shouldn't mind it either. This is typical what a patient of mine looks like after surgery with the 4 plates in the maxilla. I use 3 screws to hold things. And here's the TADs in place. And here's a patient 1.5 years later. So pre-op, 1.5 years post-op. Pre-op occlusion, 1.5 years. So, I circle this out. It's not perfect, but this is not because of the surgery. This is because of clear aligners. You won't get perfect occlusion with clear aligners, but it's good. It's still very good. So in the past, advantages for clear aligners. It's aesthetic, remove them, it's comfortable, oral hygiene, it's very good with segmental efforts. You can only do it with complete digital use. I find it faster with different cases. Patients do enjoy it. This is the big push, right? In the past, we would think low level of evidence, but not at all. I have several publications. I have now a prospective trial on 100 patients compared with full fixed and clear aligners. The relapse rate is the same. The occlusal outcome is no different than if they didn't have surgery. So no longer disadvantage. Tooth movement limitations, yes. Rotations, that's a problem. Intraoperative MMF challenge, no, not anymore. Not if you use the clear aligner splints. Refinement aligners post-op, right? That's normal. It's like post-op ortho. You have to do that extra step of removing the attachments. Again, it's good for digital use. Post-operative open bites you do get with the clear aligners because of the clear aligner thickness, but again, that's not because of the surgery, that's because of the clear aligners. And no difference is the compliance. You don't have good compliance. Amelia Kong is an orthodontist. She did her master's at Michigan, and she did studies with Lucia Sevedanes about pre-surgical workup comparison with clear aligners and how accurate it can be. So the decompensation, it works really well. This is a great article that she wrote. What do we do with segmentals supplementing? We'll add these little palatal splints. So this is a picture of the splint in place. Here's the maxilla, big expansion, small change to the occlusion. So I finished the mandible, I finished the maxilla, and at the end I insert this, and this will stay in place for 6 weeks. Here's an example of another type of splint that I'll use. This is the clear aligner splint that I've now trimmed down. So the patient gets to wear this. They can take it off. It's held with elastics, but it will help with my transverse expansion. And I'll keep this in for 20 years so that the expansion doesn't, sorry, 20 weeks. So this is the chaos splint. What I do now, this is in-house. I make the palatal splint myself. I'm able to, this has only been in the last 6 months. I use Nemo Studio, Nemo Cloud, Nemo Server, Nemo Tech, Nemo Fab, so it's all the Nemo Tech planning. That's what I use for all my in-house things, and it's been a game changer for me. So I do all these things myself. So some tips with clear aligners. You have to remove all the attachments before they see me for the workup. 4 passive aligners need to be made. I don't use the clear aligner, use a clear aligner orthognathic splints. Don't make the post-jump aligners. So go all the way up to surgery, rescan them to make your post-jump aligners. Don't use the ones that they'll send you. It's a waste of money. Rescan these 6 to 8 weeks post-op. I try to make sure that the patient can open at least 2 fingers to get rescanned afterwards. And then you can use the aligners to hold elastics, but I find these tend to fall off, so use the buttons. So clear aligners are not a contraindication for orthognathic surgery. Here's a typical case, VME class 2 deficient chin, and it's all based on the occlusion. You got to stop surgeons when they're presenting their cases and ask them to look at the occlusion. Because I'm going to show you a beautiful face outcome, but I'm keeping the occlusion here. This is what's most important, because with this, I can get this. Still keep them a little VME. You never want to bury patients too much. You change them too much. This is just a nice, subtle change. So the last little bit here, I'm just going to go into the digital planning, in-house planning, some of the limitations. We've seen an explosion, right, of digital planning, computer-aided CAS, machine learning, everything. It's affected numerous fields and industries. I can't pretend to be an expert in that, but I find we are using it as a crutch and perhaps becoming too dependent on it. And I'm going to pick on custom plates for a little bit. I picked on Marpies and the orthodontist. Now I'm going to pick on custom plates and surgeons. So custom plates, patient-specific implants, are quite useful. I've used them. And what they are meant to do is designed to eliminate the need for 2 splints, and it's basing the movements on the bone, not the teeth. Remember that. So several opinions. The people who are using it and pushing it, they're like, this is the greatest thing that's ever happened in surgery. It's the most accurate thing in surgery. They're all over Instagram. They don't need interim splints. Okay, that's about the only thing I agree with. Opinion 2, what I believe is BYOP, YNOPS. You're all wondering what the heck that is. I'll show you. It makes you overly dependent on the digital plan. It puts our clinical acumen in the hands of the digital engineer and sometimes artificial intelligence. It is a huge push by industry. Industry's pushing us, not our outcomes. It's very expensive. It is not quicker. Okay, you don't need 2 splints. I'll give you that much. Remember, I've done cases. I do some patient-specific, and it's very specific why I use them. Outcomes, they say in the publications that it's equivocal, but there's an asterisk there because it's not equivocal. They don't have long-term studies. They do not show the occlusion. My recommendation is bend your own plates. You're not a plastic surgeon. Don't mean to offend any plastic surgeons that might be listening to this. Some of my best friends are plastic surgeons. I work very closely with them. This was come up by plastic surgeons because they don't know how to bend rigid fixation plates. Right? Bend your own plates. Surgeons know how to do this. Maxillofacial surgeons are world expert in bending facial plates. And it takes me 7 minutes to bend 4 plates at 1/50th of the cost of a patient-specific implant with much better occlusal accuracy. And the only thing I have control in my life, Dr. Hussein introduced me, I'm the program director at U of T, friends and family, kids. I have no control of anything in my life except for one thing, and that's the vertical position of the maxilla when I do orthognathic surgery. And that's key. You don't want to bury patients up too much. You don't want to overexpose. And if you use patient-specific implants, you are stuck. You put in that plate and the patient has no tooth show, you are, as we say in Italian, you're up a creek without a paddle. So prefabricated plates has some pros. It's very accurate for the bone, 100%. You can do both jaws at the same time. Might be quicker for only using one splint for IMF. However, it's expensive. If you get a little bit of the plate infected, the whole plate gets infected. It does take much longer. You have to strip significantly more. If you have thin bone, you're popping in so many holes, you ruin the bone, and you can't even put on your regular plates. It is accurate for the anatomy, not for the occlusion. And you have no control of vertical dimension. So show me the occlusion. So that's a problem. Also, the digital splint manufacturing, at least in Canada, is extremely expensive. We have public health care. Our hospitals will not cover this cost. In the US, private insurance may cover it. They don't do a lot of the things that we do. In Canada, it's completely different from the United States. We have universal health care, like many of you that might be listening here. Or patients will have to pay for the rigid fixation plates. So we can't afford to do that. In the old days, this is a picture of my little room as I enter my condo in Toronto. I do 6-7 orthognathic cases per week. This is 1 week's worth of, this is 4 years ago. This is all the waste that would come to my house. And this was all to make all these splints. All these splints came in all these boxes. The waste was tremendous. And this is $1,000 per splint that would cost me. So I said, I'm not doing this anymore. So I do this all now in-house. So this is a picture of my splints in my office. This is my fellow, Dr. Tal Kapucha. He put this on, he goes on Instagram. So I'm able to print. This is 1 week's worth of splints. This is what they look like when they come out. So I use a 3D printer. I use the rapid shape printer distributed by Straumann. I use a scanner. I use a Trios 5 scanner. Again, I have no conflict. No one's paying me to say this. So this is wonderful because it's very small. And it's handless. And after a while, you wouldn't. I take the scans. I take pictures of my patients. I take the scan. I take a picture of the occlusion. I do the centric relation record. I do the pre-surgical preparation for patients. I hold their hand. I tell them what it's going to be like. That's my major input. Because as you see here, I'm presenting to you, I have a picture of a patient post-op that's out of focus, and it's a big case. It drove me crazy. So it's been 5 years. I do all that all by myself. I use Nemotech, as I said, as my software. It is wonderful. I used to use Dolphin 3D. The Dolphin 3D platform is 32-bit. So I switched to the 64-bit of Nemotech. It's much better, much more accurate. I can do everything. Orthodontist uses this a lot. It has a small orthognathic module, but super powerful for prostho, implants, ortho. Again, I'm not paid for them, but they've been a game changer for me. It took me a couple of years to find the best resin, so I use a specific resin now that works in my rapid shape. My very first machine was a Formlabs 3 plus, and it took 5-6 hours to make my splints. Now with the rapid shape, 20 minutes to make 2 splints, very quick. But you have to understand, I'm still dependent on patient-specific implants. But here's a combination of where I did my splints and patient-specific implants. So this is a patient from Holland Bloorview, condylar agenesis. It's a Pierre Robin sequence, essentially. Surgeries that had failed in the past. So the whole movement is to replace the joints, advance the mandible, maxilla, and chin. And I can only do this with digital planning. So here she is beforehand. I got a nice pan. This is dentition, good pre-surgical workup, decompensations by the orthodontist. Here she is decompensated, ready for surgery. I first place the joints, and then I correct the occlusion with the Lefort. These are extended joints, so I'm able to get some projection on the mandible, and then the genioplasty. I use the Zimmer Biomet total joint replacement, which is patient-specific. I also use TM Joint Concepts, but for the orthognathic, I use my in-house system. So I get this all together where I want. I get the DICOM back and plan for the surgery. And the patient goes from this to this, with good projection, good change, good occlusion, good range of motion, all based on the occlusion. So I'm going to finish up just with a review, because we have a lot of, even in North America, and not to maybe just pick on the orthodontist for a little bit, because orthodontists tend to get on the bandwagon for things pretty quickly. I remember years ago with TADs, everything had to be treated with TADs, and then everything had to be treated with bollard plates. Now everything has to go with Marpies, and it's kind of fading away. Now orthodontists are all engaged in sleep apnea ortho. So I see a lot of getting on a bandwagon or getting into these fads and sort of normalizing. So last year I was invited by Dr. Michael Maloro, who many of you know, world famous. He's the chair at University of Chicago. Dr. Kwan in Korea, Dr. Shi in South Africa, Dr. Borba in Belgium, Dr. Reneke, Professor Reneke, who's now in Belgium, and myself wrote this article, so predicting the future focus of orthognathic surgery. What we tried to do, and this is the article if you want to read it, or if you have difficulty falling asleep, this might help you a little bit. But the article kind of focuses us on looking at several objectives with regards to orthognathic surgery and trying for us not to get too much on a bandwagon. So it has to be outcome driven. We have to focus also on a value based, like what are we really doing? How are we really helping our patients? We need to look at expanding horizons. A lot of our patients are getting older. There's a huge difference between doing a bimaxillary surgery in a 17-year-old and an MMA advancement in a 60-year-old. Lots of differences with bone and healing. Nutrition is key. We've been ignoring nutrition for years. I place my patients on a specific nutrition catalog. I provide them with specific types of immunotherapy, powders for wound healing. We totally lost focus on that. We have to look at that. We got to look at more rapid and less invasive orthognathic surgery. A big fad now is minimally invasive orthognathic surgery. Yes, we all want to be minimally invasive, but at a certain point, these are fad things that we have to be careful of. It has to be evidence-based. Look at the way I dissect your literature. It has to be clinically relevant. So we're focused on virtual surgical planning, patient-specific implants. Remember, I'm not dissing the PSI, but for it to be used for routine orthognathic surgery really limits you. They are very important. 3D printing, acrylic and titanium, we do both. Tissue engineering, bone cement, looking at, instead of titanium rigid fixation, we're using different materials, biodegradable materials. In-house point-of-care workflow. What I'm doing, I don't think is pioneering, but I think what I'm doing is the way eventually surgeons need to go to, because you have full control of the case, you have full control of your outcome. AI, VR, outpatient orthognathic surgery is very important for minimizing our hospital stay. And again, basically looking at our geriatric population, minimally invasive surgeries, endorsing and getting to grips with clear aligner therapies, patient setting quality. So all these little things we have to focus on, not just that one little element. So finally, a couple of recommendations. This is mostly to my orthodontic group and also to boost surgeons that might be listening. You have to work with a neuromaxillofacial surgeon that works with orthodontists, who does orthognathic surgery. I don't, again, mean to diss my plastic surgery colleagues, but plastic surgeons, unless they have an oral surgery degree, don't know orthognathic surgery. They don't know the teeth. They don't know occlusion. They are limited. You must use a maxillofacial surgeon. I can't believe some, even in Toronto, there's a couple of orthodontists that, anyways. We have an expression in North America, don't drink the Kool-Aid, meaning don't jump on bandwagons. So there's obsession with sleep apnea and appliances. Sleep apnea is very complex. Careful of your TADs, your anchorage, surgery first. Just be careful of it. Don't make everything. Scrutinize your literature, especially with regards to MARPI and DOME. Remember, DOME is nothing but a SARPI. Clear aligners in orthognathic surgery, as I told you, are just fine. Not better. They're fine. We can still work. Learn how to work with it. Prepare, educate your patients, and for goodness sake, take study models as you're moving along. Be knowledgeable, not critical about OGS complications. What I mean by that is sometimes I'll get a patient, I've seen them in 6 weeks, 8 weeks post-op, and their wound is open, or they have a little infection, or a screw's open. The last thing the patient needs is the orthodontist to go, oh my goodness, the wound. You got to go back to the surgeon. This is... No. You need to know that wound dehiscence happens 30% of the time. It's not the end of the world. It's not an urgency. Be knowledgeable. Help the patient if they have a complication. Try not to be critical, because I have thick skin. It doesn't bother me, but it affects the patients, or the patient's support and trust. Relying too heavily on digital planning is a problem. You always have to keep that in the back of your mind. We don't want computers taking over our lives. And remember, the one quote I want you all to say when you listen to my talk was, show me the occlusion. I want to see that good occlusion at the end of surgery. I don't care how fast you are or how sexy you look on Instagram. You got to show me the occlusion at the end. If you ever come to a surgery meeting, I'm going to the international meeting in a few months in Singapore. Anytime there's an oral surgeon presenting and they know that I'm coming up to the microphone, they know that I'm going to say, go back a few slides, show me that occlusion. I have no problems criticizing it. And that ends my talk. There we go. Hopefully you found that interesting. So these are QR codes for patients, for ortho preparation, and the video that patients have to watch prior to my surgery. Thank you all very much. And as I said, if you come to Toronto, come visit me. My office is right over here.
Thank you very much, my dear Dr. Marco community, for very nice and interesting lectures. Thank you very much. I appreciate a lot your speech. So now we are opening the door for question and answering. So let's see if you have any question from the audience. The first question say, if the case was treated to class 1 in the past, you don't go to surgery first?
Right. No. So that's an example of where I'll do surgery early. And that's the typical. So in the Korean literature, it's all about the surgery first. But I'd say 30 to 40% of the Korean literature patients had previous orthodontics when they were teenagers. They're still class 3. They didn't want surgery, and then they wanted surgery in adulthood. So that's basically for me a decompensated case. But I'll tell the patients and practitioners, put the braces on, and I'll do surgery a month later, at least with some orthodontic appliances. They need to have some level of decompensation. The problem with surgery first, again, is not the orthodontic issue. The issue is the surgical issue. The issue is orthodontics. Because I'm happy to do maxilla advancement, mandible setback surgery, but then the patient goes to see you. It becomes an orthodontic nightmare. So in our region, East Canada, Northeast US as well, we do very little surgery first because the orthodontists do not have time in their busy offices to babysit all these cases with the elastics. So remember, surgically it doesn't affect, I'm happy, I get to do surgery, I'll see the patient a few weeks later and then off they go to your office, but then you have the challenge. But that's your most common scenario. It's a compensated class 3 that's had previous ortho, so there has been some level in alignment. And then, do surgery early, but get braces on, prepare the patient. Jumping them to surgery without, it just becomes harder.
Yes, thank you. What about aligner surgery and surgical tats for to tie? Yeah.
Applying TADs. So I apply the TADs at the time of surgery. So the patients come to me 1 month before. All the attachments are removed. The patient has to present with 4 passive aligners when they're in my office. I won't scan them until I see the 4 aligners, and they know to bring them to show me. And then when they come to my office, I take pictures. I scan the teeth, I do the STL file, I'll mesh everything in my Nemotech, and then they go to sleep. When they go to sleep, the first thing I do is I do a little enameloplasty for the predictive occlusion, and I put 8 TADs, 1, 2, 3, 4 in the maxilla, 1, 2, 3, 4 in the mandible, and my TADs aren't really TADs. I use rigid fixation screws. They're 1.75 millimeter by usually 8 millimeters, and I leave them a little bit proud of the gingiva. And I use those during surgery for wires and after surgery for elastics, and they tend to stay in place for about 6 weeks. They will loosen with time. The elastics will cut into the gingiva. So at 6 weeks, I tend to remove them because it can really mess up the gingiva depending on sometimes the anatomy of the alveolus. So they're not specifically TADs. They're rigid fixation screws, and I'll take them off at 6 weeks.
Thank you very much. We are taking the last questions. Any tips or guidance note regarding the ortho work for upper and lower midline correction pre-surgery?
Sorry, say that again.
Do you have any tip or guidance note regarding the ortho work for the upper and lower midline correction pre-surgery?
So midline correction is Oftentimes, if we know it's a surgical case, so most common would be a prognathic asymmetry mandible off to the left. If the maxillary midline is on or close to being on, then correct, and you really need to focus on the mandible, you can do the minor corrections in the maxilla. But the mandibular asymmetry should try to be focused on pogonion. Leave the midline where it is. Do not swing it to the maxilla. Leave it in line with pogonion, because I will correct that with the asymmetry of the surgery. So asymmetry correction, that's probably the background of this question is hard for ortho to figure out. Very rarely do we see an asymmetry in the maxilla. Not in non-syndromic cases. Asymmetry of the maxilla is usually dental. Usually missing a tooth or tooth size discrepancy. And that can be corrected orthodontically if you want to match the tooth size discrepancy or if they have peg laterals. That you should still do orthodontically. So it's rare for us to skeletally have one. The only reason you'll have a maxillary midline discrepancy is if it's the mandible that's tilted and canted due to, let's say, a condylar hyperplasia, and it's canted the maxilla, and that's brought the midline over, right? So that's skeletal. That's about the only time we really see a mandibular, a maxillary midline discrepancy. Mandibular midline discrepancy is almost always due to condylar unevenness, hyperplasia or hypoplasia, right? And that's corrected skeletally, not dentally.
Okay, thank you very much again, my dear friend Dr. Marco Caminiti from Toronto, Canada, for very wonderful and nice, amazing presentations. I'm looking forward to see you again in another opportunity, either virtually or in person, maybe one day in Canada, or maybe in my country, in Kurdistan region of Iraq, and we are more than welcome from now. Thank you very much, and by the way, I have a certificate of appreciation for you. Send it to you later by email.
Thank you. Thank you, Dr. Hussein, and hopefully your group enjoyed the talk. And as I say, I got my email there. If people have questions, I'm happy to answer them. And I'm not the fastest at email, but
Mhm.
I look forward to meeting all of you, and good luck with everything. And I hope you enjoyed the presentation.
Thank you very much and have a nice time, please. Take care, please. Goodbye.
Thank you. Goodbye.
Bye bye.